Radiation Protection Lesson 10 covers pediatric radiation protection, the clinical application of ARRT at its most important. Children are the most radiosensitive patients we image. They are also the ones with the most years ahead for radiation-induced effects to develop. We cover why pediatric patients are different, how radiosensitivity changes across the lifespan, technique optimization, immobilization, shielding, the Image Gently campaign, and dose monitoring. 13 minutes. For reasons pediatric imaging demands its own approach. Higher radiosensitivity. By the law of Burgony and Tribando, cells that are rapidly dividing and undifferentiated are most radiosensitive. Children have rapidly dividing cells throughout their bodies, not just in growth plates. Active bone marrow fills the entire skeleton in young children, not just the axial skeleton as in adults. Growing thyroid, lens, and gonads are all especially sensitive. A child at age 1 is approximately 10 times more radiosensitive than an adult. Cancer risk per unit dose is 2 to 3 times higher in children. Longer lifespan for effects to appear. Radiation-induced cancers have latency periods measured in years to decades. A child irradiated at age 5 may develop cancer at 25 to 35. An adult irradiated at 60 may not live long enough for a stochastic effect to manifest. Lifetime attributable risk is much higher in pediatric patients. Different anatomy and technique requirements. Pediatric technique charts are not scaled-down adult charts. Using adult calibrated AEC without adjustment on a small child results in overexposure. Pediatric-specific technique charts are required for every age group. And ARRT is most critical here. The Image Gently campaign, launched in 2008, exists specifically to address pediatric dose reduction. Nationally, no imaging without a clear clinical justification. Every unnecessary repeat exposure in a child is especially significant. This bar chart shows relative cancer risk per unit dose, from fetus through age 60 and beyond. The pattern is clear and the registry tests it. Risk is highest at the beginning of life and falls steadily as the patient ages. Fetus and neonate at the top, highest radiosensitivity of any patient population we encounter in radiography. Age 1 and age 5 remain dramatically higher than the adult baseline. By age 40, risk has fallen to roughly 25% of the pediatric peak. By age 60, it is approaching 10%. The clinical implication, an adult technique applied to a child is not safe at any size equivalent dose. The risk profile is fundamentally different. A dose that carries low stochastic risk in a 60-year-old carries 3 to 5 times that risk in a 5-year-old, because that child has decades of life ahead. For an initiated cell to develop into a malignancy, pediatric technique charts exist for this reason. Use them. They are not optional. 2 simultaneous goals in pediatric imaging: diagnostic image quality and the absolute minimum radiation dose. Technique adjustments: increase KVP and reduce MAS. Relative to adult values, the 15% rule applies. Here as everywhere. Use the highest KVP consistent with adequate contrast for the anatomy. Very young infants. Manual technique preferred over AEC. The AEC minimum. For shielding considerations specific to pediatric imaging. Gonadal shielding. More critical in children than in adults due to greater genetic sensitivity. Apply when the gonads are within 5 cm of the field edge and shielding will not obscure anatomy of clinical interest. For males, flat contact shield directly over the testes. For females, shadow shield. Hanging from the collimator, preferred because the ovaries are deeper and their position is more variable. Note, the ACR and AAPM issued updated guidance in 2020 and 2021, recommending re-evaluation of routine gonadal shielding in digital imaging. Institutional policies vary. Know the clinical rationale. The ARRT still tests the traditional standards. Thyroid shielding. The pediatric thyroid is highly radiosensitive. Shield whenever the thyroid is near or within the field. Especially important for chest radiography, cervical spine, and dental imaging. Use a thyroid collar or drape. Collimation is always the first line of protection, shielding reinforces it. Lens shielding. The pediatric lens is radiosensitive and the ICRP has lowered the cataract threshold significantly in recent years. Use leaded eye shields for facial bone, skull, and sinus projections. Angle the beam away from the lens whenever positioning allows. Documentation. Document shielding applied on every requisition. Document when shielding was intentionally omitted and the clinical reason. Audit shielding compliance. As part of your quality assurance program, parents ask about shielding. Be prepared with a clear, honest answer. The Image Gently campaign, launched in 2008 by the Alliance for Radiation Safety in Pediatric Imaging, is the national framework for pediatric dose reduction. 5 principles. Reduce. Use child-size technique for every pediatric study, not adult technique scaled by weight. Maximize. KVP, minimize MAS, lowest dose digital protocol. For the exam type. Shield. Thyroid, gonads and lens whenever appropriate, without compromising diagnostic quality. Document every decision. Speed. Fastest exposure time available, high MA, short time. This reduces both motion artifact and dose. Simultaneously. Limit the minimum number of views necessary for the clinical question. Every view adds dose. If one view answers the question, one view is the right number. No additional views taken, just to be safe. Justify. Ask before every study, is this imaging medically necessary? Especially for repeat or follow-up studies. Is there a non-ionizing alternative, ultrasound? Or MRI, that would answer the clinical question? The clinical benefit must outweigh the radiation risk. In children, that calculus is stricter than in any other patient population. The dual bar chart on this slide shows 2 things for the same chest radiograph across 5 age groups, effective dose in orange, and relative cancer risk in red. The dose values are similar across age groups for the same exam. The risk values are not. Same dose, very different. Consequences depending on how old the patient is. This is the fundamental case for pediatric-specific technique and dose management. It is not just about minimizing dose, it is about recognizing that the same dose carries a categorically different risk profile in a child than in an adult. For monitoring elements for the pediatric QA program, diagnostic reference levels, or DRLS, are national benchmarks for typical doses in standard pediatric examinations. If your department's doses consistently run above DRLS, for pediatric exams, technique review and optimization are required. Exposure index monitoring, track EI and D1 after every. Pediatric exposure, not just when the image looks wrong. Pediatric exposure creep develops unnoticed, only. Systematic tracking catches it. Repeat analysis, track repeat rate by view, by exam type. And by radiographer. Acceptable repeat rate is under 5 to 8%. A high repeat rate in pediatric imaging is a serious dose problem. Every repeat is 100%. Additional exposure to the most radiosensitive patient population. Parent communication, parents will ask, how much radiation is my child getting? Be prepared. Use honest, clear context. Comparisons to background radiation, to flight equivalents. Anxiety reduction in the parent reduces anxiety in the child. A calm child moves less. A child who moves less needs fewer repeats. Fewer repeats means lower dose. 3 Pediatric radiation protection questions. These are clinical scenarios, think them through before the answer appears. The answer is B, children have more rapidly dividing undifferentiated cells and a longer life expectancy. 4. Effects to manifest. By the law of Burgony and Trivendo, radiosensitivity correlates directly with rapid division and lack of differentiation. Cancer risk per unit dose is 2 to 3 times higher in children than adults, and the longer remaining lifespan gives radiation-induced cancers more time to appear. The answer is B, the AEC minimum response time may cause overexposure. Infants require very little radiation for adequate exposure. If the required exposure time is shorter than the AEC minimum response time, 1 to 5 milliseconds, the AEC cannot terminate quickly enough. The result is significant overexposure. Manual technique. Using pediatric-specific charts is often the safer approach for very small patients. The answer is C, use pediatric technique charts, collimate to the anatomy, apply shielding when appropriate, and justify every study. These are the 5 image gently principles: reduce, shield, speed, limit, and justify. Adult technique charts scaled by weight are not appropriate, neither is ordering additional views. To avoid a repeat, as every view adds dose. Reducing KVP below what is needed for adequate penetration would require more MAS to compensate, raising dose rather than lowering it. You covered pediatric radiosensitivity and why it matters, the lifespan risk chart, technique optimization and immobilization. To prevent repeats, gonadal thyroid and lens shielding, the 5 image gently principles, and the dose reference level and monitoring program. These are the highest stakes protection decisions you will make in your career. Every child you image deserves the full application of everything in this lesson.